I'm Dr. Erin Elliott.
And I'm Jason Tierney.
I'm a dentist.
And I'm a dilettante. And we're going to talk about sleep matters because
sleep matters.
Welcome back to another episode of Sleep Matters, where Dr. Erin Elliott and I will talk about sleep matters because
sleep matters.
How are you, Erin?
I'm great. I'm excited to bring more information to the dental profession and those outside the profession so we can keep talking about sleep.
For sure. And you're super blinged out today, huh?
I guess.
Yeah. Well, wonderful. Well, today we are talking, we spent a lot of time talking about adult airway issues. We're doing something a little different today. So why don't you kind of take the lead and introduce today's guest?
Well, I would like to introduce one of my favorite people in the whole world, Dr. Johnny Ukich. Dr. John, he goes by in his practice, is a pediatric dentist in the Coeur d'Alene, Idaho area, and one of my first friends when we moved here in 2003. Both Johnny and I came at the same time. Him and his wife became good friends. We played soccer together, did Ironman. Well, Johnny and my husband did Ironman together, raised our kids together. So we have a long history. He did his he grew up in this area. He's a second generation pediatric dentist. He graduated from Wheaton College, went on to Marquette University for dental school and pediatric residency for him to beeline it back home to Coeur d'Alene. He has recently kind of uncovered the Airway connection. And so I just wanted to have him talk about his journey and his conversion per se.
Oh, if we've got a conversion story, let's hear it.
Awesome.
What does that mean, John?
I saw the light as Erin finally said, "Praise the Lord." So, yeah, early on when Erin started getting into the sleep arena, she came to me and just said, "Hey, we need somebody in the kids arena." And I think us pediatric dentists are sometimes in the trenches dealing with cavity bugs, and we maybe don't have our eyes open to all the other issues. And we weren't trained on it, honestly, in residency or in dental school for that matter. Maybe the newer generation is, but we weren't. And Erin saw it and brought me in, and it just kind of planted a seed. And it took a little bit to grow, but I've grown since then. So I'm happy to share and however you want me to do that. So.
Yeah, I mean, kind of what was that? I mean, you mentioned being in the trenches and everything, but I mean, talk a little bit more about sort of what that reluctance looked like.
I don't know if it's a reluctance or if it is, I don't know. You feel like you get in these fads of different things and people wonder, is that really something we need to be kind of worried about? My background a little bit so I went into practice with my father, and he was pretty big into the early ortho treatment, early interceptive ortho treatment. But again, it wasn't zeroed in around airway. It was kind of like orthodontics, facial development, that kind of thing. And so when I came out of dental school and residency and came back with him, he definitely pushed that towards me and encouraged me to do the same thing for our patients. But right around that same time, we saw kind of the self-ligating brackets, the so-called the Damon brackets and the night-tie wires that really developed out arches beautifully, that got the results that younger or that older generation of dentists, where there was the tweed mechanics where they were extracting four bicuspids and it was really dishing in the face and affecting the profile. And that's what my dad was looking at. He wasn't looking at the airway, but he saw that. And unbeknownst to him, what he was doing was helping the airway. He just didn't realize that's what he was doing. And so as I came along, it was not part of the repertoire of what we were discussing. And as the orthodontics components started getting better and they weren't extracting, we started just sending more of our orthodontic cases to the orthodontist to do it all in one round. And So again, we focused on the bread and butter of dentistry and cavity bugs and all of that, and kind of started stepping away from doing as much orthodontics. And I think it's all these conversion stories start with your own kid, I think. So one of my kids had kind of this history of open mouth breathing, kind of a little bit of open mouth snoring or mouth breathing at night, family history of bedwetting a little bit to where, we just chalked it up to, oh, that runs in the family. It's just genetics. And, then you plant these seeds. One of the local orthodontists gave me the book Gasp. And I think when I read that, that is what a light bulb went off. All these things, what Erin was doing, all the things that she talked about, all this early treatment orthodontics that my dad had done years before, looking at my own kid and doing kind of arch development around the age of 12, but still seeing some of this open mouth breathing and stuff that just couldn't put my finger on what was going on. And then reading that book, and it was just like kaboom, all this stuff kind of came together to where I realized, like, holy smokes, this stuff needs to be looked at way earlier than what we're doing. And all these people that have all this apnea stuff at, age 40, who had typical traditional orthodontics at age 12 and have beautiful smiles, but have these kind of weak airways, like we missed something. Like, what is it that we missed? So I kind of dove all in, and started doing some treatments. And lo and behold, 2 weeks into expansion, we got kids stopping wetting their beds. Like, parents are coming in like, what in the world? You said this might happen, and it totally happened. And then kids are like, I can breathe through my nose. I can blow my nose. Their parents are like, they're sleeping better. They're different behaviors. And I mean, once that happens, once those things happen, it's like Erin said, you can't unsee it's just, so now it's like you just are eyes wide open, kind of looking for it everywhere. So
how much time elapsed from when you started practicing until you had that epiphany?
do I have to answer that? I feel like that's it. I think probably 20 years.
So what would you say to the guy, the dentist that's getting into practice today? What would you say to yourself 21 years ago, right? To try to bring that to your attention and open your eyes to it and open your eyes to it, at that time.
That's a really good question. And I think that's a hard one because I feel like you come out of dental school, out of residency, or out of a GPR. I mean, you're just like laser focused on, I got to pay off my debt. I got to get in there and just learn to do what I've been trained to do. And I think the first few years, you're just kind of deer in the headlights, go, just trying to learn and get your skills down. And so you throw something like this in there. If it wasn't in your education component, you're like, why did they teach me this if this is really that important? And so I think it's hard. I think it takes a little bit to get that. But I sure hope it's something that is starting to be incorporated into the educational arena to where these kids are getting those seeds planted young. And then it just grows as they realize this is something I got to watch out for. So, I mean, early on in our training, it's like, hey, you got to learn to take somebody's health history and determine whether or not their cardiac issue is something I need to worry about. What are the meds they're taking? But they don't ever say, did you ask airway questions? Did you ask anything about that? Even if they just start planting those kind of seeds, like immediately you start to know this is something I got to pay attention to. So if they can get their eyes away from kind of that day-to-day bread and butter and start to feel comfortable with that, I think that's when we can start kind of planting these seeds of how it is important. I do think there's people that are in the adult arena that are just like, hey, this is a moneymaker. I want in on it. But I don't think they're necessarily doing it initially for the right reasons, but ultimately they're helping their patients, which is good. So
it is a labor of love.
We went all in the sense of like, okay, we, as a pediatric dentist, now have a cone beam. Like, not very many pediatric offices have a cone beam. We got a rhinometer to measure kind of airway, acoustic rhinometry to measure nasal capacity and airway. We bought an iTero, and we're doing scans on these kids and measuring arch widths and showing the scans of parents and talking through all that. So we invested heavily into a lot to do that. And that's tough for a new provider, but you don't need to do all that stuff. I don't think. I think you just need to be asking the right questions, looking for it. And if you're aware of what you're looking for, we have all of our patients fill out a PSQ, a pediatric sleep questionnaire. And if they score high on that, it is like immediately a discussion point for parents starting at the age of 3 and 4. I mean, we're putting kids in expanders at the age of 3 in some instances. So
That's what I was gonna ask is what is, like, the sweet spot of screening and age? Like, so we kinda took matters into our own hands of, like, what, 8 years ago? Um, Trying to build a team, in this area. We just kinda brought it in-house, but, of course, we don't get exposed to as many kids, and they have to kinda seek us out. We always said, like, 4 to 5 is the sweet spot for compliance, because we use a removable, orthotic, but are you putting expanders in the palate, and what age?
yes. So I do agree with you. I think treatment 4 to 5 is the sweet spot. The research, I believe, shows that you want to try to get these in before the age of 7. I think it's like 80% of the arch development and the airway development happens by the age of 7. And so if you can get in there earlier, you're helping to curb that growth direction and those habits that are so kind of developed out. Yes. So we use fixed expanders. Primarily, we do carry and use the myo brace. I just haven't had a lot of great consistency of wear that's really shown like use like changes. I've seen kids use it and it worked great, and it was, but more or not, the parents come back frustrated their kids won't wear it and they're fighting with them. And so sometimes at the age of 2 to 3, we'll start with that to try to get them moving in that direction. And then around 3 to 4 or 5, if they can tolerate it, then in goes the fixed expander for them.
For those kids that are not compliant, and you're having those conversations with the parents about things they can potentially do to increase compliance. What do you suggest?
Typically, it is more daytime wear. If we can get them to use it a little bit more during the day where they are getting more comfortable with it and really working on that lip seal around the appliance and breathing through their nose, then they're able to tolerate it at night. And we tell them it's a marathon. It's not a sprint. The expander is kind of like a sprint, within 2 to 3 months, we've got you fully expanded. The nighttime orthotics are something they're going to take a year to 2 or consistent wear to grow and develop. So it's just
Do you
their
feel like
approach.
the orthotics are good for, like, training nasal breathing, tongue place, tongue posture, tongue tone? I know the expansion's slower, but it could also act as a habit corrector, right? For those
You
kids
bet.
that are thumb sucking and have a sucking habit, they kinda like it. I feel like the kids are a lot of times more compliant than the parents.
Yes, 100%. This is a myofunctional issue, 100%. And you can make the space all you want, but if the kids don't know how to use their lips and their mouth and their tongue properly, because most of the time they're not using it properly, that's why they're as narrow as they are. And so you make them their mouths bigger and then they just kind of keep doing the thing they were doing. So that's right where it helps to do that. So a lot of times after the expansion, we'll give them a myo brace to wear. And we'll also possibly coordinate them with a myofunctional therapist to kind of work on those habits so that they're not unraveling everything we just did. So
you're a bit of an outlier here. So what are your colleagues, your peers think about what you're doing?
I mean, it's funny. I've got one co-resident that is big in this as well. I don't know if you know Boyd Simpkins, Erin. He
I
speaks a
do.
little bit.
He
Yeah.
went to Creighton.
Yeah, but he went to
Yeah.
Children's Hospital, Wisconsin for residency.
Okay.
So we were in residency together.
Cool.
And I saw he was a speaker at one of the AAPMD meetings or something. So I called him up and he's like, man, I've been blacklisted everywhere. He's like, everybody thinks I'm crazy. He's a little more of the orthotropics kind of treatment where he's not as concerned about bringing the teeth together for aesthetics. He's just really opening their bite up, kind of the Mew technique a little bit more. And so anyways, he's gotten a lot of resistance. I haven't seen that as much. I just kind of get the ha ha ha. I mean, or not necessarily people were kind of, they give you that side look of like, are you buying into this? And I mean, I'm like, you guys are missing it. Like, this is super important. I was where you are. And so a lot of them, their excuses, they just like, I'm so busy, I don't have time for that. And I've got a great relationship with the orthodontist. And luckily, our local orthodontist that's big in Airway is like, Johnny, you need to be seeing the kids. He's like, I can't see the little ones. It's just not my deal. And so, again, I was a little resistant for a while, but have come around. So I'm hoping that my colleagues will do the same eventually. So
When you broach airway or concerns about, airway with patient or with parents, how receptive are they typically? And I mean, what does that conversation sound like?
yeah, I feel like I'm a little more, I don't know if we all are this way, but I don't want it to be salesy. I don't want them to feel like I'm trying to sell them on something because it's not cheap. It's a big investment. And so I think that pediatric sleep questionnaire is key. Honestly, I'd say maybe 40% of the people who fill out that pediatric sleep questionnaire mark 0 all the way down the entire list until somebody says, hey, I noticed little Johnny is over there with his mouth open. Does he breathe like that at night? And the mom goes, yeah. I'm like, how about, does he snore a little bit? Is he a little snorely like his dad? Like, oh yeah, he totally is. But they marked 0 on it. But if you ask the right questions, you kind of pay attention, you start opening that up, and then you start to develop this. I think what I tend to try to say is, hey, I'm not so worried about your kids sleeping at night in the sense that if they're staying in bed and they're not bothering you and they're letting you sleep, they're not climbing in bed with you, because that's usually when parents are frustrated because they're not sleeping. But they write their kids off as good sleepers. And I'm like, have you ever watched them sleep? And they're like, oh yeah, their sheets are torn out all over the place, or they snore like, logs, but they sleep great. And I'm like, well, are they really? The quality is what we're worried about. And I say, I wear a sleep device at night, and I'm amazed at how much my sleep is affected by a late night meal. And I slept all 8 hours, but I got horrible sleep. So I said, we don't have that for our kids, and they don't have a way to tell us. But we know that if they have any of these mouth breathing, snoring, restless sleeping type of things, Darth Vader breathing, airway resistance, then we know their brain is not getting into those deep sleep cycles, and they are not getting the necessary quality sleep that is going to help with their growth and development. And I think that usually is what sinks in. So I say, from a book I read, they just said, hey, you guys are the lifeguard for your kids. You need to be peeking in on them while they're sleeping at night. You need to be making sure that that's the case. And if you're noticing any of these symptoms, then they likely have an issue that we need to address and can develop into these sleep apnea issues as adults. And I'm amazed when I say that, how many of them say, oh yeah, their dad has sleep apnea and he wears a CPAP, or I have sleep. The mom says I have sleep apnea. And I think that's where, we know, it's a huge percentage of the adult population is wrestling with this. So it's only obvious that their kids are potentially, that they're worried about their kids down the road. So
I feel like the consumer is a lot more educated now. I'm going to ask about your infant tongue tie releases later, but how much are people seeking you out for this now?
It's becoming more. I don't think we've done, an amazing job of advertising for it other than kind of our own patients. I think we're trying to kind of start that now that I feel like we've got our protocols and our systems down to where we can handle that. And we know where to refer when I feel like, okay, I think we could do some good work, but I think this kid has some ENT issues with, tonsillar adenoids or allergies, or they really truly have a myofunctional issue that needs to be addressed first. Let's get you to that team member first. We've been utilizing our local craniofacial chiropractor too to get them seen there if we see some postural issues. So trying to let them know, hey, this is a team approach. This isn't just about the pediatric dentist putting in these banners and magically fixing your kid. There's a lot more going on here. And we need to be looking at all these factors. So I think there is a reception, and I think a lot of people, like you said, Erin, are seeing this, are more aware and coming in with questions. We try to plant the seed a lot of times, and it might take 6 or 12 months, so like a recall or two before they come in, eyes wide open, ready to really fully talk about it. So we try to just at least broach the subject gently, make them feel like they're not being sold a bill of goods, But there are those that I mention it and they're like, where do I sign up? I'm like, wow, I didn't even explain everything. And they're like, we don't care, we're in, so, which is great.
I love that.
Erin, you're gonna ask something about
Oh,
appliances. Yeah.
well, he has a Celea laser, and he can use that on hard tissue fillings without anesthetic, things like that. But I really am not set up to do infant tongue tie releases. I'm doing adult and some older peds. But we only had one person, and that was just in the last 4 years. Before that, people were driving to Portland. And so I just kind of wonder how the reception was, how you set yourself up for that, and the success you're seeing.
Yes. So prior to the Stolea, we had a BioLace hard soft laser, and we were able to do infant releases with that as well. It hasn't been a huge market, and I don't know if it's the male component where we've got a female pediatrician in Spokane that seems to have a pretty good relationship with a lot of the lactation consultants and some of the chiropractors that are seeing these young infants. And so I know she sees quite a bit more than we do, but we see our fair share. And there are certain times where we're looking at the kids going, I don't know that this is your issue. And I think you need to go back and work with your lactation consultant to work on kind of the coordination of the muscles rather than freeing up tissue ties. Sometimes they end up coming back, which oddly enough, when they do that, it sometimes exposes some of these ties a little bit more. They kind of get released from posture, whether it's a craniosacral chiropractor doing some releases to get their posture better, and then they're not so kind of positioned wrong. And then it does show that there is one that's tighter, that's affecting the latch or the milk release. And but those are super rewarding. Gosh, you release this, we have the mom's nurse immediately right after. And I mean, nothing makes your day, your month, your year than you do that. And the mom's just like crying, like, oh my gosh, like I thought it was me. They're struggling with this new baby that, usually it's the first time moms that really have that. A lot of times the moms of other kids usually, no, it's not me. I've nursed 4 kids already. Something's not right here. And so, but the other ones take it personally. And when you can show them that it wasn't anything they were doing wrong, it's not their inexperience as a mom. It's just these simple little tissue ties that are just making it really hard, if not impossible, for these little ones to nurse properly. So in addition to that, the value of the nursing that develops out the arches. Our medical community is maybe encouraging just to go to a bottle. And now these kids are feeding fine. And so they're not, thriving, but now they're missing that connection with mom. Mom's missing that connection with baby. And now these arches are developing smaller because they're not nursing from a breast versus a bottle. So it's a huge win. And so the CO2 lasers are definitely a game changer. They are so slick. They heal up amazingly. No bleeding. They're super fast and comfortable for these kids. And it is. It's challenging on these little tiny ones. You see these little, days old babies, and but they do really, really well. And a lot of them, honestly, our assistant kind of sits there with the slow speed suction. and many times they don't even cry. It's kind of like they're mesmerized by that little suction, and we're like, nope, didn't cry at all. So pretty amazing.
Absolutely. So to your peers that say they're too busy, that they can't really do this right now, what would you say to them? Meaning fine, you don't have to treat these kids, you don't have to be involved in that, but as far as what signs, symptoms should they be looking for, and when they identify those kids, what should they be doing then?
Yeah, I would definitely first say I would recommend that book, Gasp. Another one, James Nestor, Breath, is another one that's just easy to get into and read. It speaks our language. It's just going to resonate with what we see. And I think what happens is they're just unaware of what it is they're looking at. And when they hear it from that side of things, it's like your eyes get opened up to kind of what it is you're looking at day in and day out. And you're like, whoa, okay, this is a problem. I may not be the one to treat it, but at least I can recognize it and I know what to do or where to send them or what to at least talk about with mom. Because the reality is we see these kids, every 6 months from like 1 year old, and more so than a lot of times the pediatricians or any of the other care providers. So we're ripe to pick this up and recognize some of these developmental issues. So um, I think that alone is just like, hey, you don't have to have every solution. You don't have to go buy all this fancy equipment. You don't have to even do this if you feel like this is not your thing. But you need to be able to recognize it, and you need to be aware that this is a thing. This is super important. And unfortunately, we weren't trained on it, but such is life. We got to get up to speed, and you don't have to go to some fancy courses. There's lots of stuff out there that you can do, but just being aware and reading up on what it is that we're looking at day in and day out is going to be helpful.
Do you think your Academy of Pediatric Dentistry it's in the guidelines now, finally? I mean, it took forever and there was a lot of fighting about it.
Mhm.
And now they're saying you should screen and treat. Is that going to move the needle at all? Did it move the needle for you at all?
So, I mean, I definitely think it didn't move the needle for me. I think I was already there. Uh, but, the one thing of dentistry versus medicine is quite a few, especially in pediatric dentistry. I think it's like 97 to 98% of pediatric dentists are members of the APD. And we're all, in order to have a hospital privileges, we all have to be pursuing board certification in pediatric dentistry, which requires us to do specific CE every year. And they deem what that is. And we have to be up to date on all the new kind of regulations that AAPD puts out there as far as standard of care. So I think it comes across all of our plates because it kind of has to for us to keep kind of specializing, keep our specialty board license. So I think that, yes, that is huge. That will help kind of definitely move the needle and, make it more
Talked about?
talked about and kind of real versus kind of, oh, there's those people out there that believe in this.
Sure,
So,
sure. Yeah, as you're talking about this, Dr. John, I'm just thinking about, Erin with the ADA, and the guidelines there, and how many dentists just ignore it, right? Ignore that voodoo airway stuff. But yeah, if it's part and parcel to retain your licensure, it's a different story.
yeah.
When I first started talking to parents about their kiddos, I would kind of approach it similarly to you. Once I explained it, then I would have them redo the questionnaire after going home and maybe watching their kids sleep. I just say 20 minutes, for a couple nights, and then fill out the questionnaire. But I do coach them. And I said, if you mention this to your pediatrician, they're going to say, oh gosh, Erin again, she is crazy. I said, just take that with a grain of
You're not
salt.
wrong.
Yeah, yes. I think I have said that. They're not wrong, but I'm right about this. Do you have to have the pediatricians in this area kind of come around a little bit, or do you have to coach them similarly?
I think, well, in our area, we have two main groups, pediatrician groups. I think one has come around. The other one is a little maybe reluctant. We've been trying to get in front of them. We got in front of one of the groups just to kind of explain what's going on and the fact that this is a thing and this is important. And like, this isn't pretend. And they were all ears, asked some great questions. And I think they just think that we just see somebody who's narrow and just say, oh, we're going to throw this thing in there, charge you a few $1,000 and all your problems will be solved. And I was like, no, that's not what we're doing. Maybe people are doing that, but that's not what we're doing. This is where all the issues are. How can we bring you guys along? Do you want these patients seeing you? And most of them are like, no, it's great that, as long as you're filling parents in and they're able to explain it to us, if we ask questions, then we feel like we're all on the same team. So I think that was a great meeting to have. We've been doing, in addition to the mild brace, the mild munchie, and trying to really just at a young age, trying to get this neuro stimulus established at a very young age where we're helping to, so with that, we've got to start getting these kids off pacifiers like at 6 months of age rather than at 2 years of age, which we are all trained to do. Because so much of the arch.
How long did your kids use their passy?
Yeah, I'm not answering that. So
I know these
they're
things.
driving down the street right now.
Yeah,
it was a while.
2 3/4, Erin. So
Yeah.
that's to that one. And my dad was like, Johnny, you need to get them off of that. And I was like, I don't know if I can handle what's going to
I didn't even know how to talk, Jason.
Yeah. So,
just kidding.
Yeah, they cruised around with it in there for a while. But one of them needed an expander to correct a crossbite. The other one didn't. And which made me think of a story, or made me think of one of yours, Erin. We put an expander in one of Erin's boys. In addition to one of my own. But the way we were treating was we were expanding the upper arch to match the lower arch. We were not thinking that when the upper arch collapses, the lower arch collapses and narrows in to match the upper. So we would get the upper out so that it was symmetrical with the lower. But we were not thinking to expand the lower so that we could really get the upper arch way out to where it needs to be. So now if we put upper expanders in, we're getting 8 to 10 millimeters minimum every time. And so we have to put a lower expander in to match that. Otherwise, you're going to have this huge buccal crossbite. But you've got to get both arches out because the lower arch just won't unravel that much. It'll unravel some, but not to the degree that it's necessary. So
now's a good time for us to play a little game with you. Okay? This is called the final countdown.
coming back.
Okay.
I never knew that one.
What's the worst movie of all time?
Ishtar.
Okay. That's a blast from the past. And then you're getting ready to enter the ring for the battle royale. What's your theme song?
Welcome to the Jungle.
Guns N' Roses. All right. Well, Dr. Johnny Ukich, thank you so much for joining us and sharing a little bit with us. And I'm confident that there's someone that was on today that will listen to this, that will hear something new and take some necessary action and go out and change lives just as you have. So thank you.
I appreciate it. And thank you, Erin.
Yeah.
Love you. And thanks for bringing me along and being patient with me along the way. So
Thanks, bud. It was awesome to have you on.
Sleep matters.